Hello, can everyone hear me? Okay, great. I apologize for the delay. The person who usually starts the meeting was not available at the last minute, so we were scrambling to get it started. So thank you for sticking with us. I'm just going to wait a few more minutes. Hopefully we didn't lose too many people.
And Matt, I'm only here for a partial amount of time because I have to go into another place. I'm at Kansas City Medical Center today.
Okay. I don't see anyone else joining. We may have a short meeting because of the technology issues. So we can just do some introductions and then go ahead with the plan that we had for today. I just want to make sure, Mahalit, are you online? Are you able to hear us? I think I see you joined. You're just muted right now. Just want to make sure that you can hear us.
Hi, Matt. Are you talking to me, Maria?
Oh, Maria. I'm sorry. I saw M.
I'm sorry. It's Maria Hanlon. Yeah, with CHS.
Okay. Welcome, Maria.
Thanks. That's just my issue. Right.
Oh, okay.
On my computer. Yep.
Well, let's continue with introductions. Let's start with people who are on the phone. So we just had someone join. The number is 619. That's the area code. Go ahead and introduce yourself.
Hi, this is Brianna Reeser. Sorry I can't get on the Zoom video. I'm having a hard time with my computer. I'm not sure if anyone else is having that same issue, but I'm with Care First. I'm an integrated health program manager, and I've been on a few calls, and that's my introduction.
Welcome, Brianna. It wasn't your fault. It was our fault. We were having trouble starting the meeting.
Oh, okay. Got it.
Okay, let's continue with CH011018.
Hi, I'm Shelley Gosnell. I work for Spectrum Healthcare. We're a fully integrated healthcare facility in Arizona.
Okay. Welcome, Shelley. Thank you.
Thank you.
Next, let's go to Maria Colon.
Hi, I'm Maria Colon. I'm a DBH doctoral candidate, and I work in Florida in a rural health clinic and a fully integrated clinic.
Wonderful. Thanks, Maria. And then I'll introduce myself. My name is Matt Martin. I'm the director of this ASU ECHO group, and I'm part of the faculty here at ASU. Let's go to Leslie.
Did you say Leslie, Matt?
Yes, Leslie.
I was like, I thought I heard my name. Hi, everybody. I'm Leslie Manson. I am also on faculty at ASU for the DBH program. So welcome, everybody. Glad to be here. And I'm going to escape a little early because I'm actually a guest of Kansas City Medical Center today. So.
Cool. Thanks for fitting us in, Leslie. And then let's go to Mahalit.
Are you talking to me, Matt? Maria.
Oh, sorry. Mahalit just joined.
Mahalit, someone else? Okay. Oh, I see Mahalit.
Hi, can you guys hear me? Okay, so my name is Mahalit Walker. I'm an intern for ASU ECHO this summer and part of the undergrad for ASU College of Health Solutions.
Okay, wonderful. And then let's go to, was it Maria Hanlon? Is that right?
Yes, that's correct.
Okay, okay. And tell us more about yourself, Maria.
Well, I'm just joining as part of the, I guess, administration with Project ECHO with College of Health Solutions. I've already been in the college for several years with medical informatics.
Okay, so you're part of CHS administration?
I'm part of CHS, that's correct.
Okay, okay. And for those of you outside of ASU, CHS is the College of Health Solutions. Okay. Wonderful. Well, I think most of you are familiar with ECHO, but I'll just give a brief introduction. So the purpose of ECHO is to connect individuals and organizations and to create a collaborative learning network. the network includes experts like those of us here at ASU, as well as people who are out in the field who are trying to implement and improve best practices. And the purpose of this particular ECHO group is to focus on management strategies in integrated behavioral health. So we meet together about once or twice a month, and we focus on strategies that help to develop protocols, workflow, policies that help to make integration more successful. So today is our 8th meeting, and we don't have a case presentation scheduled for today. In the past, we've usually had a case presentation where a clinic will talk about what they're working on, what they might be struggling with, and then the rest of the group will provide suggestions for how they can address the problem. So we don't have that scheduled for today. What we wanted to do, and it's going to be abbreviated today, we just wanted to talk to those who are on the call and ask them about things that are going well at their particular site, as well as maybe one thing that they would like to change or to improve. And the reason we wanted to have this discussion is because up to this point, we've kind of been guessing, well, educated guessing, what some of the topics are that we should discuss. But moving forward, now that we've had a few sessions under our belt, so to speak, we want to have a better target for the kind of topics that are really meaningful and important to the group moving forward. So with that in mind, let's just start this discussion. And for those of you who are part of systems or part of clinics where you're interested in this kind of work, tell us one thing that is going well at your clinic or among the several clinics that you oversee. Tell us one thing that's going well, and then also one thing that you would like to improve or change. And then we can have a discussion from that. So we have a small group today. So I'm looking at any of those who are on the call, if they would like to start and just tell us a little bit about your site, and then things that are going well and things that you would like to improve. Would anyone like to go first?
I'll go first.
Yay, thank you, Shelley.
You're welcome. So I work for Spectrum Healthcare. Initially, we were a behavioral health facility. We've incorporated physical health, primary care health, with also chronic pain management into our facility. I am the whole healthcare consultant, and so I'm connecting our physical health patients with mental health care. And this is brilliant because a lot of what I did during my capstone was focus on the study of depression in a primary care setting. And I'm capturing a great deal of those and getting them the help that they need. However, the one thing that I'm discovering we have issues with is the screening processes. There's some kind of a disconnect. I have a screener that needs to go out to all primary care patients. And I have tried getting the front desk to give them to the patients when they check in. I've tried the MAs who room the patients to hand them out and get them done. And it works great for a while and then stops. And that's pretty much it.
Okay. So how long have you been working for Spectrum again?
Since August of last year.
Okay. And tell us your role again at Spectrum.
It's a whole healthcare consultant. I connect the primary care patients with behavioral health.
Okay. All right. And tell us more about the kind of screener that you're looking for. Is this for medical or behavioral health?
It's for behavioral health. It is basically a combination of the GAD-7 and PHQ-9.
Okay.
It's a standard assessment tool. Yeah.
Yeah.
Okay. Excellent. Okay. Would it be helpful for us to talk about that right now?
If you would like, yes.
Okay. So yeah, those are both validated tools, the PHQ-9 and the GAD-7. It sounds like you're wanting to identify patients that have some type of mental health need, whether it's depression or anxiety, and then you want to connect them with the mental health providers. Is that right?
Correct.
Okay. And it sounds like you're thinking of having the nursing staff, the MAs, distribute these questionnaires. Is that right?
It is. I do have a questionnaire that I developed in need of primary care or physical care, but I just have difficulties having those distributed to the patients. I've tried several different things and it just seems to work great for a while, and over half are positive. And then it just kind of seems to stop and doesn't go anywhere.
Yeah. You cut out a little bit, but it sounds like you've had some trouble sustaining these,
yes.
these protocols. Okay. Yeah. And are you, just to get some more information, are you wanting to implement this at one clinic or multiple clinics?
Right now, we're just currently doing the one.
Okay. Okay, great. So I've got some ideas. I'm sure Leslie has some ideas. Is there anyone else before we chime in, Maria or Brianne, that would like to just share your experience with using screening measures? This is a very common, challenging issue.
This is Maria. So my question is, are the scales in the electronic health record, or are they paper forms?
We have the screener that is paper form, and when the screeners come back positive, I do the electronic forms.
Okay, so have the screeners received training on what happens if the scales are high? Do they know what to do?
Yes.
Okay, and they're not concerned about, one of the things that I found is that sometimes they're concerned about doing the PHQ-9, and especially the question number 9, which talks about suicidal ideation. That's been a concern for anywhere that I've integrated. What do we do with this information? So like Leslie said, Dr. Manson said in her chat, it sounds like it's a workflow issue. Like, do they have a clear perspective of what's going to happen once these forms are filled out? And what's the next process after they do that? Do the patient stay in the office? Does the patient see a primary care provider that same day? Does the patient see you that same day? So all of that workflow, if they don't feel comfortable with it, then it's not really going to happen.
Right. They're very aware of how it works. We've
Okay.
been doing this for almost a year now. If the screener comes back positive, the patient is supposed to take the screener to the primary care provider. Then the primary care provider will hand them off to me, and then they will be set up for services the same day. So it's just that the front desk it's almost like it's not really important. It's great for a while, and then all of a sudden they stop doing it, and then I have to go back out and reiterate. Mm-hmm. And that lasts for a couple of months, and then it drops down again.
Yeah, I've seen similar issues before. Who manages the front desk? Who's that individual?
She has an office right at the front desk.
Okay. Is she under clinical management, or is it like financial?
And has also been, I think it's more of a financial.
Yes. Okay. So that there might be a lack of connection then between the financial side and the clinical side, and I've seen that before as well.
Okay. So more education, is that?
I think it sounds like there are multiple strategies that you can use. One of them would be training, just to help people who do not have a clinical background to understand the value of these questionnaires, but also to understand how common depression and anxiety are in primary care, and how important it is for those individuals to receive treatment. So that can be part of your training, is just the answering the question why. Why is this important? And then the second one is training on the specific protocol that you've developed for the screening. You may also want to include the management in that training, or at least have meetings with them where you're explaining the goal that you have, the rationale behind it. Especially the financial manager, they often have they're focused on the financial piece, and so they're not involved or have as much investment in. That's not the right word. They don't have as much day-to-day work on the clinical practice side. So it may be worthwhile to sit down with the financial manager to talk with them about your vision.
Okay.
Can you talk more, just to go back to the workflow, talk more about what happens if there's a positive screen? It sounds like there's a same-day referral to you.
Yes. Typically they are handed the patient is handed the screener by registration. They're supposed to fill it out and take it to their primary care provider. Then if it's positive, the primary care provider will refer them to me. And it's a warm handoff.
Okay. So from there, you meet with the patient, you provide some kind of brief assessment or
education, yeah, and intervention, and also if they screen really high for me, I will refer to behavioral health, and then I can do the full intake process. So. Oh,
okay. Yeah. And then what happens with documentation and then circling back to the medical provider? What happens there?
There's a specific area that I document in there that has to be signed off by the provider so that they're fully aware of where the client stands. Yeah, all of that is in there. So.
Excellent. I mean, it sounds like you've got a lot of pieces for an effective workflow. It's just about sustaining it and getting management support. Yeah. So I have another thought, but I'm going to see if Maria or anyone else on the call has any other thoughts.
Okay.
The only other thought is sometimes, so it sounds like you're using what's called like a universal screening approach, where everyone that walks through the door gets the same screening, and there are lots of benefits from that. First of all, it simplifies screening. Everyone gets it. So the nursing staff or the front desk staff, it's easy for them to catch on to that. Mm-hmm. Second is that you can help to identify people who have subclinical issues that might not come up if they had like a full assessment or if they came in for other problems. The only downside to the universal screening is that sometimes it can start to burn out, not burn out, but it can be very easy for fidelity to that protocol to go down because we're doing it every day, we're doing it with every patient, and people kind of take it for granted after a while. So one thing you could consider is to do a more targeted screening where you're focusing on patients with particular conditions. So it might be like all the diabetes patients or all the patients with chronic pain or a number of different medical or mental health conditions. You could just target those patients. So all of those patients that come through the door, they all get the screening. The challenge, though, is that it makes the workflow a little bit more complicated.
Yeah.
But it may help. It may help in terms of the sustainability because then you're only focusing on these particular patients that are usually at risk for depression and anxiety. Shelley, would it be okay if we were to follow up with you in the future just to see how this is going?
Yeah, absolutely.
Okay. Based on what you've heard today, what do you think you're going to do?
Well, I had a couple of ideas. I see, like I said, when I do get the screeners back, there's, let's say I have 7 screeners in one day. There's always either 5 or 6 of those that are positive. It's a significant amount. And I have done the education of all of the clients involved, or patient, or the workers involved. My thought was maybe having some kind of a flyer in the lobby where they check in, saying something along the lines that depression is situational. So you're going to be screened every single time, so that the patients aren't getting upset at being screened all the time. Because I think that was one of the drawbacks that people said that they had, was the patients were thinking, I don't want to fill this out.
Yeah. Yeah, that's another drawback with the universal screening. So the patients, are they screened at every visit, or just at the new patient visits?
Typically, we're screening everybody that comes in.
For every. Okay, so for every visit. Okay. And it sounds like you're getting a lot of positive screening results.
A lot.
And how many behavioral health providers are at your site?
Oh my gosh, at our site, well, we have 2 buildings, actually 3 buildings, because we have it like a Tri-City area here. So at our particular site, we have 3 psychiatrists and 3 therapists. And then we have 3 primary care providers and 1 chronic pain management provider.
Okay. And how many of you are there?
1.
Okay. Yeah. Yeah, that's pretty normal. What's the wait time to go see the therapist or the psychiatrist?
The psychiatrist is about 2 weeks out. The therapist is closer to 4.
Yeah. Yeah. So I'm thinking more and more that you may want to consider a more targeted strategy, so that you're looking for those patients that are a little bit sicker or more at risk, ones that would really benefit from mental health treatment. Those are the ones that you can identify and then move them forward to treatment and support, as opposed to getting a lot of positive screening scores and having a really long wait time, a long waiting list.
So I don't know if you guys can hear me, but what I was thinking, as well as you were saying that, Dr. Matt, is that she can probably focus on those new patients coming in. It's a possibility to kind of narrow it down for now only on new patients. And I don't know where your office is located, if it's close to the person that's doing the screenings or close to primary care. How easy is it for them to bring you the screens? Because if
we're all in the same building.
Okay, but are you like very close or in the back of the building and the other person is way in the front? How does it work?
No, we're all within just a few rooms of each other.
Okay, so basically you're there all the time and they know that you're there as well. So that's a great thing. But if you were to target it, basically when we started the integration, not here in a different job, what we started was only with the new patients.
Okay.
Because that helped us narrow it down, and then the front staff, because the new patient usually has a packet.
Right.
We did all the copies and we included the forms in the new packet. So every new packet that was being given to the patient had these forms integrated in it already.
Right.
So if that can be something that can help. And then from there, the follow-ups, we had the MAs do it, but we had them in the electronic health record. That's why I asked, because they would fill it up there, and then from there it popped up directly into the provider's note, where the provider, even before seeing the patient, if they reviewed the electronic health record, had that note. Then we also had the communication with the MAs and the nurses. So even before sometimes the provider saw the patient, the MA would come and talk to me and say, Maria, I think this one is going to need your help. So I would talk to the provider and say, hey, can I go and do a brief interventions while you see the other patient, and try to alleviate that, so the provider really didn't have to address that to a full if I wouldn't have gone before. So trying to have that connection with those primary care providers is what really helped me improve the integrated program where I was.
Okay.
Thank you.
Thank you very much.
You're welcome, Shelley. thank you for sharing that with us. I wish there were more people on the call who could hear that, because that's a very common issue.
Yeah.
How do we identify these patients that need our help, and how do we work them through the whole pathway of treatment? Okay, so we'll try and follow up with you, Shelley, to get some more info.
Okay.
We had someone new join us. Let's do an introduction. Daniel, can you hear us? And do you mind introducing yourself?
Yeah, sure thing. Sorry, I was running late. I was coming out of a referrals tracking training. My name is Daniel Need. I'm a clinical health psychologist at an FQHC in Maui, Hawaii. I'm currently covering as the interim integrated health director while we're looking for someone to take the position permanently. So I've been in integrated care about 5 years. And so we're slowly building the program here to have more of a behavioral health consultant, behavioral medicine model. So just figuring out the best ways to do that.
Wonderful. Well, we're glad you're here. We have a small group today. We had some technology issues. But what we're doing today, Daniel, is we're just going around, and each clinic is just talking about what's going well at the site, and then what is one challenge that they're dealing with as well.
Okay. Yeah.
We're getting some background noise. I'm going to mute you, Brianna. I think we've got some background noise. Brianna, you're welcome to unmute yourself. So Daniel, will you tell us a little bit more about your site? Tell us one thing that's going well, and then maybe one thing that is challenging that we could possibly discuss today.
Well, one thing that's going well is for plus and minus, when I got here 2 years ago, there was me and one other psychologist. And since then, we've had 2 directors in the position who have come and gone, and some staffing changes. But now we're sitting on a staff of myself, a pediatric psychologist, an LCSW who primarily does tobacco cessation, but is also expanding her mental health role, 2 CSACs and a nutritionist, and then a psychiatrist that's 1 day a week in a consultative model. So we have a lot of good pieces. We have a lot of dedicated people. We all get on well. It's kind of the challenge right now is, 3 of those people have come on board in the past 6 months, and our old director left in March. So the transition of where the department is going now and how to piece this together. Our CMO is very involved. He is a big advocate of behavioral medicine and having us involved in like diabetes co-visits and hypertension co-visits. We just opened a transgender clinic that both our psychologists are very involved in for doing like the intake assessments and ongoing care. So there's a lot of cool stuff happening. I'm a little overwhelmed with it. Just kind of, you eat the elephant bite by bite. So it's a supportive staff. It's just a lot of moving cogs right now.
Mm.
So I guess maybe my challenge right now is time organization or project organization, kind of making sure I'm keeping all the plates spinning in the way that I think I am, and I'm not forgetting any plates, and also seeing patients and all of that stuff. So,
so right now, Daniel, you're the interim director, and you're also continuing to see patients as well. Is that right?
Correct.
Okay. And are you in charge of any supervision or training responsibilities?
No.
Okay.
No.
Okay. All right. Well, it sounds like you've got a multi-professional team, a lot of different services provided at your site. will you tell us a little bit more about your patient population? You said it's an FQHC.
Correct. We have a lot of patients. We have a kind of an interesting mix. So we have a large Pacific Islander population, a lot of people from the Philippines, the Marshall Islands, and Micronesia. Then we have a lot of kind of mainlander transplants on the kind of older side, probably 50 and above. We have also have a very large homeless population that we see for a variety of reasons. Sorry, I'm getting paged right now. Also, then we have kind of the local population, which is a mix of Native Hawaiian or second or third generation Japanese, Filipino, Korean, kind of. So we have a kind of a mix of culture, a mix of populations, a mix of service needs for sure. We have a lot of methamphetamine use here. That's a huge problem. Probably meth and alcohol are our two biggest substance abuse issues, and the things that come with that, as far as hepatitis C and HIV and a lot of the communicable diseases that come from injection.
Okay.
Yeah, we have the only OB clinic on the island that takes Medicaid. So we have a lot of high-risk OB patients. Yeah, there's one other FQ on Maui. They're on the other side of the island. It's a 2.5-hour drive from here. So we're functionally the only FQHC on Maui. So we pretty much cover the safety net for the 200 and some thousand people that are here.
That's incredible. My goodness. You mentioned, Daniel, that you've got a very supportive and invested CMO, which is fantastic to hear. Can you talk more about other stakeholders or other executives that are involved or maybe not involved with the integration?
Yeah, I mean, honestly, our CMO has been here about 2 years. He came in to make change, and he's made change. And so he's been very good about making sure the executive, like the C-suite, is on board with what he's doing. It's been a slow build to explain, kind of moving away from what was, when I got here, essentially a co-located mental health model that they were calling integrated care, but really just doing kind of warm handoffs for mood stuff. And why it was important that we were involved in diabetes care, why we're currently working with our lawyers to talk with the state Medicaid offices because they're not reimbursing the HMB codes. And we're trying to explain to them, why that's important given the high rates of diabetes that we have here, that alone. So the upstairs has actually been not necessarily super involved on the day-to-day stuff, but they are very supportive in listening to what we need and giving us the time and, even the financial space as we're kind of transitioning to a different practice model and say like, yep, productivity is going to dip because we have to sort of retrain the clinic on what our department does and retrain the patients on what our department does. And not every visit's going to be billable necessarily, but here's kind of a long-term game plan. And there's obviously been some reluctance because there is always reluctance with change, but overall been very supportive and very, very much advocates for what we're doing.
Awesome.
And also don't totally understand what we're doing. So they're supportive, but they don't always know how to be, which is fair enough.
Yeah, there are a lot of other, I'm sure, initiatives and tasks that they have to manage. So that's understandable. Will you tell us again what's the model that you're moving toward at your clinic?
We're moving towards kind of on the SAMHSA scale, we're kind of a 4 right now. We'd like to move more towards a 5. We'd like to be seeing kind of more patients for brief intervention in primary care, and doing fewer follow-ups. It's a lot of our patients, it's hard to get them in the office because of transportation or childcare or whatever it is. So we want to take advantage of being able to see them while they're here and not make them come back for a separate appointment.
Yeah.
That.
Okay, so a very highly integrated healthcare delivery system.
Yeah.
So okay, so it sounds like the current thing that's on your mind is how do I keep all these plates spinning? And the spinning plates is always a problem. You can't keep them all spinning at the same time. You can spin one and then put your attention and spin a different one. But attention is a precious commodity that we're always short of, and it's impossible to keep all those plates spinning all at once. Are you open to any suggestions from the rest of the group about how to keep moving forward and to keep on top of all these initiatives?
Yeah, please. I am all ears.
Okay. Well, it's a small group, so I'm looking at Maria and Shelley and the other Maria and Mahalat if they want to chime in at all. But if you've had any experience similar to Daniel's in terms of managing multiple initiatives and priorities, you're welcome to chime in. Maria, I think I saw a question from you in the chat area. Where is the current priority for integration? What is the limitation? But go ahead, Maria.
No, that's exactly what I was going to ask, because I know he's doing so many things, but hearing what he's saying, I want to know what exactly is the focus right now on what's the priority in the clinic. I know he said that it was to do brief interventions. So what's the limitation with doing brief interventions? Is it training? Is it that the staff is not aware how to function? Is it the workflow? Like, what exactly is that the limitation occurring to not allow the interventions how they want them?
You hit the nail on the head. A lot of it is workflows and helping the staff here to understand what the model is. I think because there was so much flux in our department, that the model has not been clear, and we couldn't necessarily cleave to one model because we'd have 3 psychologists, then we were down to 2, so we couldn't have full-time WHOs, and then we had a nutritionist added, so the model kind of had to be very flexible depending on who was in the department at the time. So now that the department is actually, at least for now, stable, there is, and we've been talking about this within the department, there is just going to have to be, I think, more formal staff education on what we do and what we don't do. We're rolling out a new referrals tracking system that will integrate with our EMR on Tuesday. So we've been talking about how to kind of change the referral process to move away from, for instance, the front desk and the medical pods won't be able to schedule directly with us. They would have to either call a consult or they would have to submit a referral. And we want to sort of pressure them more towards, let us see them while we're there. We'll figure out what the next step is. Don't bother with the referral. We'll do that for you, but you have to put us in the room. I think right now it's because of the kind of limited presence we were able to have full time in the medical part, in the medical clinics. It was very easy for a lot of the medical staff to roll back to the traditional, psychology does mental health, and kind of forget everything else we do, and then kind of just go back to all of the mood referrals. And they weren't pulling us into the room for even mood, but certainly not anything else. So I think now that we have a strong staff, or a large enough staff, that we can be more present and we can advocate more for ourselves, and we are more, we are honestly more available now, and more consistently available, we can push on that kind of formal rollout and be able to support the medical staff in adhering to that rollout, which we just haven't had the manpower within the department to do really up until now.
That sounds great, Danielle. Is there one staff that you can actually indicate that that's the person that's going to be doing the brief interventions until the staff gets used to it? Like, is there one, like your LCSW, can you target them with doing the brief interventions and then from there disseminating the patients to the other staff? Is there a possibility?
Yeah, so there's actually the myself and the other psychologist, we cover by half days consults and follow-ups. So one of the psychologists is always available Monday through Friday to do consults. But like Sophia just came on board 3 weeks ago. So between her onboarding and everyone sort of meeting her, that's been that itself has been a new schedule, never mind kind of what they can use us for. So I think this is just a long transition period. I think it's just a long transition, but it is a transition. We just need to sort of keep up with it.
Yeah, and I do want to tell you, transitions are difficult and they're challenging, but the more you persist, the better it's going to be for the team. But don't kind of let go of taking opportunity of Sophia that just came in, because she can actually, because she's new, she can change the way a little faster of how things are going, because she's new and she hasn't been embedded in this system for a long time. So if she comes in with a brief interventions model, knowledge of how it's supposed to function between diabetes, hypertension, and the mental health issues that the patients have, not including all the SMI, which are a little bit more complicated, then that can help. And that's why I said it's good that you and the other psychologists are there, but don't underestimate a new person coming in, because they see them as new and they're going to be like, okay, so this is the process and this is the way that we're going to do it, and incorporating those workflows into the clinic as well.
Great comments and questions.
Yeah, thank you. I like that.
Yeah, we have about 7 minutes left. Daniel, this is fantastic. Thank you for letting us know more about your clinic. Shelly, did you have any other last questions or comments for Daniel? You're muted right now. I know, I forget too sometimes.
Daniel, are you guys using any type of a format to start this integration process in your facility?
You mean like a formal format?
There's a couple of them that I came across when I started doing this for this facility, and they kind of give you a guideline or an outline to follow. It was helpful for some things.
Okay. Yeah, if you, off the top of your head, if you know of any, that would be wonderful.
So it's called Behavioral Consultation and Primary Care, A Guide to Integrating Services.
Yes, I know of that book. Yes.
That was one of them that I went through. And I also know that if you go to the American Psychology website, that they also have some integration stuff on there.
Yes, yeah, that's a good point. I think I have a lot of things bookmarked and saved that I probably need to take a weekend and print out and really go through with a fine-tooth comb.
Okay.
That's
probably all I
probably,
got for you.
Yeah, I'm probably at that point. So you're right. I probably really do need to buckle down and maybe come up with a formal written plan at this time.
And just to say one more thing, I know Dr. Manson, I don't know if Dr. Martin is, but I know Dr. Manson is a consultant for integrated care around the US, because that's something she told us when we gave the class. So maybe you do want to bring a consultant into the clinic to help you guide that process.
Okay, that's not a bad idea. Thank you.
Thank you for that, Shelly and Maria, and thanks again, Daniel. I'm just so impressed with your clinic, with your team that you've put together, and with you. I mean, you're the director, but you're kind of not the director, you know, because you're interim, and they're going to fill that position. So that's always a tough position to be in, where you've got authority, but it could change in the very near future. And so that's always tough. There's a balance between keeping things stable versus, you know, making changes and moving forward. So that's a challenging situation to be in. And then on top of that, you're continuing to see patients that have a lot of needs and a lot of vulnerabilities. So I just tip my hat to you, and I'm very glad that you've joined us today. I hope, Daniel, that you'll consider coming back in the future and just letting us know what new workflows or what new strategies that you've decided to focus on. And then one last thing, this has been on my mind a lot today. There's been a discussion on one of our listservs about resiliency and burnout. And so this is probably for all of us, that we have so many plates that are spinning, so many tasks and responsibilities. It's always important to remember to take a step back and to breathe, and to make sure that we're taking care of ourselves so that we can continue to be the best professionals that we can be in the future. So we are out of time today. We typically meet every 2 weeks, and we typically have a bigger group. We had some technology issues, and we'll have those resolved by next time. But instead of meeting in 2 weeks, I think we're going to be looking at meeting on August 9th, and we'll send out information for that meeting later in the future. But thank you everyone for coming today. I hope everyone has a wonderful weekend.
Likewise. Take care, Dr. Martin.
Thank you. Bye-bye.
Thank you so much, guys.
Thank you, everybody.
Welcome.